Good afternoon. I'm Catherine Santoro, Director of Policy and Development at the National Institute for Healthcare Management, or NIHCM Foundation, and on behalf of NIHCM, welcome to our webinar today. We've reached a new frontier in cancer care. Progress in cancer research continues to lead to breakthrough therapies, and because of advances in detection and treatment, more patients are surviving their disease. Yet the price tag of this progress is high and growing, faster than costs in any other medical sector. We're pleased to have an excellent panel of speakers with us today to explore ways to address the rising cost of care while improving the quality of cancer care. Before we hear from them, I'd like to thank NIHCM's President and CEO, Nancy Chalkley, and the NIHCM staff who helped to convene this event today, including Kate Ellis, Katie McDonald, Carolyn Myers, and Kirsten Wade. You can find biographical information for all of our speakers, along with today's agenda and copies of slides on our website. We also invite you to live tweet during the webinar today using the hashtag CancerFrontiers. Alex mentioned CMS's leadership in this transition to value-based care, and we're honored to have Lara Strawbridge with us today. She's the Oncology Care Model Lead in the Patient Care Models Group at the Center for Medicare and Medicaid Innovation, and she's leading this team that Alex mentioned that's been implementing the OCM, and she joins us today to share an update on that program. Lara?
Great. Thanks, Catherine, and good afternoon, everyone. I'm happy to be with you this afternoon virtually anyway. Just a brief overview of the CMS Innovation Center for those of you who may not be familiar. We are called sometimes CMMI or the Innovation Center. We were created by the Affordable Care Act, and our purpose really is to design and then test new ways of paying for health care and then also for delivering that health care for the beneficiaries that receive health care through CMS. So that would be Medicare, Medicaid, and CHIP. Our priorities are really, again, to develop new models, to test them, and to evaluate whether or not they work, and then in cases where they do, potentially scale more broadly, and also to engage a range of stakeholders to think about future opportunities. Overall, all of our models are aimed at a central goal that's outlined in the Affordable Care Act of reducing program expenditures while preserving or enhancing the quality of care. So we have models that range in focus from ACOs to primary care to bundled payments and state innovation. And of course, today I'll be speaking specifically about the oncology care model. So a few of the estimates on this slide were really already covered by Alex just a moment ago, but as you all listening today are likely well aware, we have millions of Americans being diagnosed every year with cancer. We have hundreds of thousands dying, and a significant portion of that population with cancer is the Medicare population. So not only that, but we have costs that are high, they're rising, and they're variable. So within CMS, we identified that oncology was an area of opportunity for us to try and achieve the goals that we do with all of our models, which again is to improve care and outcomes while doing it at either the same or lower cost. So the oncology care model has a focus on episodes of care, and I'll talk more about those in a moment, that are focused around Medicare beneficiaries who have cancer and who are receiving chemotherapy. And our goals for the model are to try and use financial incentives to improve care coordination, appropriateness of care, and also access to care. And again, the hope is that by having financial incentives that support these three goals, that we can then also improve overall quality of care, health outcomes, and either maintain or reduce costs. So I'll speak about the financial incentives in a few minutes, but the goal is that the financial incentives will hopefully encourage the participants that we work with to collaborate within their practices and also with providers outside their practice to really create a model that comprehensively addresses the very complex healthcare needs of patients who are receiving chemotherapy for cancer. So a few basics of the model. As I mentioned, for each individual that's part of the oncology care model, they are part of it through an episode. So we target chemotherapy and then the care that follows during a 6-month period of time. So it begins with a patient receiving chemotherapy and Medicare receiving that claim, and then continues for a 6-month period of time after that. Our goal is to most essentially emphasize the idea of whole practice transformation, where the practices that we are participating with implement practice redesign activities that will help them improve their quality of care and really transform the way that they do their business. As Alex mentioned a few minutes ago, we're a multi-payer model, so I am obviously representing the Medicare fee-for-service piece of the model, but we do have other payers working with us. And again, the idea here is the whole practice has an incentive to transform if you have not only your Medicare population, but also other payer populations included as part of the model. So we started last year on July 1st of 2016, and we'll go for 5 years. So we're about 14 months into the model at this point, and throughout the next few minutes, I will mention some anecdotes that we're hearing based on early implementation experience, but I do want to emphasize that we don't have any actual results yet. The evaluation has begun, but will be ongoing, and it will be some time before we can say definitively what has happened in OCM. Much of the initial year of the oncology care model, we at CMS were really focused on providing information that could help assist our participants with implementation of the model. So we were focused on the requirements and operational details of the model. We certainly continue to provide that support to our participants, but we also are really trying to put an emphasis now on sharing best practices among our participants and helping them understand and identify where opportunities for improvement might be. So it's an exciting time for us. As I mentioned, we have certain required activities that each of the participants we have in the model must do to participate, and we call them practice redesign activities. The first one is a broad category which involves 4 main components. So we say practices must provide enhanced services, and those are 4-part. One is to provide the patients that are part of the model with 24/7 access to a clinician who has real-time access to the medical record of that patient. The second is to provide core functions of patient navigation to those beneficiaries. The third is to document a care plan that contains 13 different elements that were recommended by the Institute of Medicine. And lastly, they must treat the beneficiaries that are part of the model with therapies consistent with nationally recognized clinical guidelines, or if they deviate, they must document a reason why they have deviated. In particular, I want to just highlight the third item here on the list for a moment, that documenting a care plan. I do want to note that this item out of all 4 of these, I think, has provided the biggest challenge to our participants so far. In particular, there's an element that requires that practices provide patients with an estimate of their out-of-pocket costs of care. And it's been a challenge for practices. We've worked with them and with some experts in the field to try to identify the best way to do that activity. But we have been hearing from folks anecdotally that the care plan in particular as an activity is one that they believe is improving their care as a result. In addition to those enhanced services, we have 2 other required activities. One is to use certified electronic health record technology, and the third is to utilize data for continuous quality improvement. So to elaborate on that last one for a moment, I'll say that we ask practices to collect and report on clinical and quality data to us, and I'll talk about some of the measures that we require in a few minutes. But in addition, we do provide our practices with feedback reports that are based on claims data and some other sources of data as well, such as patient surveys, to give them information to identify where those opportunities for improvement might be. We also, in addition to the feedback reports themselves, which include measures around utilization, cost, patient experience, and end-of-life care, we also provide practices with the claims data that underlie those reports so that those that are interested and have the analytic capabilities, they can really dig in and see the specific services and other care that their beneficiaries are receiving. I will note that EHRs and health IT have been a challenge for our participants in our model. It can take time for EHRs to adjust to the requirements that we have put out, and also for them, the EHR vendors, to adjust to the requests and needs of the practice as well. So there's time required for implementing the changes that we have here in the oncology care model. There's also, in addition to the technical changes that are often required, a need for a culture change where providers are really using the new fields, in particular structured fields, that EHR vendors might create for them to use. So we've been working not only with our practices, but also with EHR vendors through a work group to try to improve the ability of practices to collect data for the oncology care model and then also to report some of those elements to us. So Alex covered some of these numbers again a few minutes ago. I won't spend much time talking about the practices themselves other than to say we have nearly 200 practices participating. All of them are treating patients with cancer who are receiving chemotherapy, and they are located in a range of geographic areas and range in size. We have an incredibly heterogeneous group. We have solo practitioners, and we have large practices with hundreds of providers, and Alex noted a couple of them on his slides as well. We've heard from practices of a number of focuses that they've had early on as a way to try to improve their care and potentially reduce costs. Some of the efforts have focused on avoiding hospitalizations and ED visits. Some practices have used triage phone lines or care coordination and risk stratification through team huddles, through navigation, and other activities. Some practices have established same-day and walk-in appointments. Others have extended their hours in the evenings or weekends, or made arrangements with nearby health centers for urgent supportive therapy. Other practices have conducted proactive outreach to high-risk patients. Some practices have focused on palliative care as an early area to concentrate on, including managing pain, advanced care planning, and the emphasis of advanced care planning happening early and often, and also on survivorship planning as well. So we have a lot of exciting work happening among our participants. We also have payers participating. As I mentioned, this is a multi-payer model, so we have 14 commercial insurers that are supporting OCM practices. You may have noticed that Alex mentioned 17. We do have 17 participating, but 3 of those payers are all Blue Cross Blue Shield payers who have decided to band together under their partnership with the Healthcare Services Corporation and collaborate through that lens. So we can say 14 payers, but they together are working with us to provide that financial incentive and also emphasis on quality measurement to try to support whole practice transformation. So we and the other payers that are participating in the oncology care model convene regularly to share lessons that we're learning and brainstorm solutions to issues that inevitably come up throughout model implementation. We ask that payers that participate in the model align with us in a number of ways, including the 5 ways that are outlined on the slide here. So we ask that they provide services, payment for enhanced services and also for performance. We ask that they include at a minimum patients receiving chemotherapy as a focus. They can include other kinds of patients as well. We ask that they require similar practice redesign activities as I outlined a few slides ago. We ask that they share data with their practices that they work with and that they align with us on a core quality measure set. And I'll give a quick overview of some of those quality measures in just a moment. So we have a two-part payment approach in OCM, and again, this is the financial incentives that I've been mentioning. So we have a monthly per beneficiary payment that we make prospectively to our practices for the patients that they're caring for who are in Medicare fee-for-service. And then we also have a retrospective possible performance-based payment that practices may receive if they achieve high-quality care and also reduce expenditures below a target price. We have two different risk arrangements in OCM. So we have a one-sided non-risk-bearing option where practices are not responsible if expenditures increase during the model. And then we also have a two-sided model where practices are asked to assume some risk, and if expenditures exceed the target, then they could be responsible for paying money back to CMS. There are some additional details on this slide. I won't go into them, but feel free to refer to them, and if there are questions during the Q&A, I'd be happy to answer them. The one thing I wanted to point out additionally here, though, is that both one-sided and two-sided risk in the oncology care model are considered APMs for QPP, or quality payment purposes, the quality payment program, excuse me. So our one-sided is considered a MIPS APM, and two-sided risk is an advanced APM. So we have a number of quality measures that affect practices' ability to earn a performance-based payment in the oncology care model. We have three that are claims-based, one patient-reported survey measure, and then we have 8 practice-reported measures. All of the measures in total have a range of focuses, including utilization of services, end-of-life care, patient experience, measures around symptom management and psychosocial care, also care coordination, and then quality and timeliness of care. And as I mentioned earlier, practices also report to us, in addition to the 8 practice-reported measures on this slide, a range of clinical and staging data, which we are hopeful will enable us to create more narrow bundles going forward for calculating target prices. So we have a learning community in the oncology care model to help support our practices. It's a robust effort to try to share best practices and support practices in their implementation. We have a range of activities from webinars to online collaboration to affinity and action groups, which are smaller groups that meet together and really dig into an issue such as palliative care, using data for continuous quality improvement, and others. We also conduct site visits to better understand what practices are doing and offer support to practices where it's needed. So at that point, I will wrap up. I'm happy to answer questions at the end of the webinar today, and also happy if folks reach out to me through the email address on this slide to answer any questions there as well. Thanks again for having me.
Thank you so much, Lara. Lara just mentioned earlier that one of the goals of the oncology care model is improving the appropriateness of care, and recent research on the overuse of low-value cancer services and drugs can really help inform efforts to partner with physicians to reduce inappropriate care. And we're pleased to have Allison Lipitz-Snyderman with us today to share some of this research. She's the Assistant Attending Outcomes Research Scientist at Memorial Sloan Kettering Cancer Center, and NIHCM Foundation provided grant support for Allison's research on this topic through our investigator-initiated research grant program, and we're so grateful that she's able to join us today to discuss her work. Allison?
Great. Thank you for having me. My name is Allison Lipitz-Snyderman. And I'm a health services researcher at the Center for Health Policy and Outcomes at Memorial Sloan Kettering. Today I'll be talking about my research on physician-driven variation in low-value healthcare services in oncology. So thank you to the NIHCM Foundation for supporting my work. which is also supported in part by the Cancer Center support grants to Memorial Sloan Kettering. I'd also like to thank my study collaborators, who are a multidisciplinary team of biostatisticians, health policy and health services researchers, and clinicians. I have no disclosures to report. So low-value service use is widespread in oncology. And when I'm talking about low-value service use in this context, I'm talking about those types of services for which the anticipated harms of use outweigh the anticipated benefits. For example, cancer-directed therapy for patients with solid tumors with low performance status. So why does this matter? Low-value services and drugs are associated with patient harm, excess costs to patients in the healthcare system, as well as other negative effects. And several studies have demonstrated wide variation in the use and prescribing of these low-value healthcare services and drugs across the U.S., including differences by region, big variations by individual hospitals, and also there's a growing body of literature demonstrating that at the individual provider level, there's also large variations. So why do we care about variation? It's because it suggests that there might be opportunities to intervene, potentially to standardize practice to help maximize outcomes for patients and other stakeholders. So the focus for today will be on the individual provider level, so specifically focused on the physician. And the reason we're focusing on the physician is because physician level represents an actionable level of intervention. Also, the physician is involved at that point of decision-making of whether or not to use this low-value service. So the critical question that I'll be discussing today is what drives physicians to prescribe these low-value healthcare services and drugs? And I'll be reviewing two questions. The first is, do physicians exhibit consistent behavior regarding the use of these low-value drugs? And secondly, does oncology practice setting influence physicians' behavior? So first we'll be talking about the first research question. Do physicians exhibit consistent behavior? And we're focused on the clinical context of cancer care, since cancer care represents an intense period of potentially harmful and costly healthcare services and often a lot of uncertainty in decision-making. A clear understanding of treatment patterns of physicians' behavior is needed to help inform the direction of intervention. So, for example, if we can demonstrate that service use is consistent for individual physicians, in other words, they're always prescribing the same low-value drugs or not, it suggests that the intervention should be physician-specific and targeted potentially to these high-user groups, and also that we can learn from the more measured users. If service use turns out not to be consistent by a physician, it suggests that these interventions should be service-specific instead. So the hypothesis of our study is that physicians' practices is consistent. Specifically for this study, our hypothesis is that physicians' past use predicts current use. And as you can see on the left-hand side of the slide, our hypothesis around the correlation between use of these imaging tests, we see that Dr. A prescribes this non-recommended imaging test both for patient 1 and patient 2, and Dr. B does not prescribe that imaging test for patient 1 and patient 2, and so on. And this suggests this idea that use of this low-value test is consistent, a habitual behavior. Whereas on the right-hand side, if our hypothesis is not supported, we might see that this imaging test would be randomly distributed throughout these patients and not really directly connected to the individual doctor. Specifically around our study, we're interested in looking at whether what happens with patient 1 might predict what happens to patient 2. So to test our hypothesis that these physicians exhibit consistent behavior regarding these overused services, we took a look at some of the items from the ABIM Foundation's Choosing Wisely campaign. And this campaign asked medical specialty societies to suggest items that should be questioned by physicians and their patients. So we included 5 of these items that we were able to measure, one of them including from ASCO, don't perform PET CT and radionuclide bone scans in the staging of early breast cancer for patients at low risk for metastases. So that's one example. And these are 5 examples in cancer care of things that we might call low value or potentially overused services. So to address this issue, we use the SEER Medicare population-based data set. And this data set links information from SEER registries, which are cancer registries, which include information on patients' site of cancer, their stage of disease, their time of diagnosis, things of that nature, links it up with claims from Medicare, which includes use of health services specifically, and links up that data for patients who reside in SEER regions. And that includes about 28% of the U.S. population of cancer patients are in SEER regions. So we use this data set to create our study sample of Medicare beneficiaries who were ages 66 and older, diagnosed with cancer between 2004 and 2009. And back to our earlier example, we specified the study sample based on the specific measure that we were looking at. So for example, in the item early stage imaging, we included patients with stages 0 to 2 breast cancer with surgery within 6 months of diagnosis and no neoadjuvant treatment. We have assigned each patient to an accountable physician for the analysis. So in this case, we assigned the patient to her surgeon. We conducted 2 main analyses for this project. One, we used multivariable logistic regression analysis using a random effects model to allow us to find out how much variation there was between individual physicians. And then the second piece, which I describe here, is looking at that specific outcome of receipt of low-value services conditioned on the physician's last patient having received that service. So as you recall from the illustration, it's basically, does what happened to patient 1 predict what happens to patient 2? So for that analysis, we excluded patients whose physicians only had 1 patient in the data set because you needed 2 patients to be able to link up a lag variable there. So this is a table of our results. We found that there was significant variation between physicians for each of the 5 services that we looked at in particular. As you can see in the example here for imaging for early-stage breast cancer, we had over 89,000 patients in the data set, representing over 4,000 total physicians. About 14% of patients received this low-value imaging, and we found widespread support for our hypothesis. We found that the odds that a patient received that imaging test was 3 times higher if her surgeon's prior patient also received that imaging. And as you can see from the other examples, we found similar support for this idea that this past behavior is predicting what's happening. This suggests the idea that we're seeing consistency within physicians' behavior regarding a variety of low imaging tests. So this leads us to the question of why. What's driving this behavior? So it could be many different things. One area that our research team was interested in looking at was what's the influence of oncology practice setting on physicians' behavior. And so why oncology practice setting? So we know that there's been a shift in outpatient oncology care from independent physician offices to hospital outpatient departments. We've seen that over the past decade. There's differences between these settings, including different reimbursement structures for some of these very expensive drugs. This has prompted questions about the impact of setting on cost and quality. And there's been limited work done to assess the impact of setting on treatment patterns specifically. And so that's what we were interested in delving into in this part of the study. So our clinical context in this case was outpatient cancer care for patients with advanced disease. And we focused on patients with advanced disease because there's many very expensive drugs for patients with advanced disease that are likely to have limited or no added benefit to the patient and may even cause harm. So it's a ripe area for addressing overuse issues. So our hypothesis for this piece of the study was that physicians in private practice oncology settings order more low-value expensive drugs than physicians in hospital outpatient settings. We used similar methods. We used the SEER Medicare linked data set for this analysis, focusing on Medicare fee-for-service beneficiaries diagnosed specifically with advanced cancer between 2004 and 2011. And again, we created separate cohorts of patients based on who would be eligible for that specific drug that we were looking at. And in this case, we chose 4 different drugs that would likely be considered to be low value for patients with advanced cancer. ESAs and GCSFs are supportive care drugs that would be relevant for patients with advanced solid tumors. A variety of solid tumors were included in that grouping. And then combination chemotherapy and nab-paclitaxel for patients with advanced breast cancer. So as you can see here, there's support for our hypothesis. We found that the use of these low-value drugs in this setting was higher in physicians' office settings compared to their use in hospital outpatient departments. This is unadjusted for any patient characteristics. So for example, for ESAs, we saw that there were 16% of patients had ESAs that were low-value ESAs in the physician's office setting compared to 9% in the hospital outpatient department setting. So this graph represents the adjusted analysis that we did with these same drugs. And again, we found support for differences in practice setting. For our 2 supportive drugs, ESAs and GCSFs, we found these to be statistically significant in this model. For the therapeutic approaches, combination chemotherapy and nab-paclitaxel, they were in the expected direction but not statistically significant. Also, as you recall, this was among a smaller subgroup of patients, just patients with advanced breast cancer compared to the total. So what are the implications? So the findings support the notion that physicians exhibit this consistent behavior with regards to using these low-value services in oncology. And our findings provide some early insight into these patterns from Medicare claims. But we still are left with this incomplete understanding of the mechanisms through which these patterns exist. We don't know why. We found support for one structural characteristic, oncology practice setting, that it mattered in that context. But we don't know, is it the reimbursement? Is it that hospital physicians who practice in hospital outpatient departments may be exposed to more to what their peers are doing? They might have more standardization in terms of policies. There may be other differences between physicians. We don't know. That's an area for further study. In general, further study, we believe, is warranted to try to understand the mechanisms through which things like setting and other practice patterns might influence physician behavior, so we can translate those into effective interventions. What we found is that there are many implications for interventions at the physician level, such as trying to de-incentivize the use of these non-recommended low-value services and drugs that could be used to reduce avoidable patient harm and cost, and ultimately to maximize outcomes for patients with cancer. So thank you for your time. I'm happy to answer questions after the presentation.
Thank you so much, Allison. This work is really helpful as we think about how to align incentives to reduce low-value care. We're going to turn now to hear from Florida Blue. They're a leading innovator in building care models that are facilitating partnerships between patients and their doctors to foster better care coordination and cost-effective care. And joining us today to share their efforts is Dr. Eric Haas, the Senior Medical Director of Clinical Affairs for Florida Blue.
Good afternoon. I'm happy to be here and talk about some of our care programs with our physicians and what we're doing in terms of improving care. So we'll go to the first slide. So it's we'll be talking today about navigating oncology care, and we've got an approach here at Florida Blue that's dedicated to having a collaborative, joint effect with our providers to manage in quality of care of our members. So ensuring also that the members get the right care at the right place, to get the most cost-effective outcomes. So with our partnership with oncology groups in Florida, we took a different approach at Florida Blue in partnering in a value-based type arrangement with 3 large tertiary cancer specialty groups in the state. Moffitt, these are employed oncologists in the Tampa Bay area. Baptist South, which is in the Miami area, again, another employed oncology group. And then an independent physician-owned group that's statewide called Florida Cancer Specialists. And the way that we set the ACO value-based relationships with the groups was to reward providers for beating cost targets while meeting quality outcomes and standards. So the program has resulted in shared savings. We've maintained our quality standards. We set targets for the different groups and then measure them and provide that feedback along the way and made sure that we attributed patients in an attribution model to them. So in terms of some of the outcomes that we measure with the groups, certainly clinical outcomes around breast, colon, esophageal, pancreatic cancer, make sure that we take patient satisfaction and patient safety into consideration. And then we look at adherence to treatment guidelines. Are the physicians following evidence standard guidelines that set out by the National Cancer Society, the FDA, or specialty society, depending on the cancer? The other approach what we take at Florida Blue is we've established a care team approach. So at Florida Blue, we've placed into motion an integrated multidisciplinary team approach of clinicians that have into 11 different zones in the state of Florida, where we have typical nurse role types, from looking at patients coming into the hospital, helping patients get out of the hospital and transition. We have complex case managers that take care of oncologic patients. We've got community social workers that also assist our teams, in licensed care social workers to help with behavioral aspects, as well as clinical pharmacists for any issues as such. And how do we integrate this care? It's a hyperlocal approach, and we do it by a number of facets. So I'm going to just bullet down. So our complex case managers are triggered new diagnosed cases of patients who have cancer. They assist in a number of ways in coordinating a very complex, difficult disease for patients. They help out with coordinating to oncology visits, to follow up and making sure they're staying in touch with their PCP, their medical home, to assisting the patients in getting to the infusion sites. We have clinical pharmacists, which are just so important now with the cost of specialty drugs, and helping on complex drug regimens that are often fraught with not only severe side effects, but also the high cost at times hinders patients from really getting the care and ongoing they need. Working with the oncologist to find other alternatives along care pathways for these particular patients. Community social workers have been instrumental really in helping in the social determinants of health, which no matter whether it be oncologic disease or other core chronic diseases can really impact the end stage of a patient's outcome. Marshaling community as well as faith-based support to help from anything from meals, transportation, to housing, affordability, helping out in making sure that those basic needs are met, that's not an impact in terms of care that they need. Behavioral is something very significant as an underlying cause for non-adherence to medications, to problems with adherence to physician visits. Certainly with cancer diagnosis, behavioral needs are great that we found for our patients. And with that, not only helping the patient, but more importantly, the caregivers and family Our licensed care social workers have been very instrumental with the population that we serve who have cancer. Our teams are led by a nurse manager called a population care manager that reports up through our regional medical directors. Our regional medical directors have been instrumental in having peer-to-peer discussions with oncologists as well as primary care doctors on the difficult cases, helping patients in terms of where services can be rendered, such as some of the previous speakers talking about site of service of care. Certainly we encourage where possible to have infusions, for instance, done in the physician's office, outpatient, rather than subjecting patients to readmissions, cyclic into the hospital or into the outpatient hospital setting. Many patients have benefit designs within their plans that they will pay a significant higher amount out of pocket if they go into the hospital or if they use the outpatient hospital for ongoing oncologic needs versus having a physician being able to do it in their office. Likewise, the medical director may also have discussions on other care alternatives. Again, most patients have a different benefit design if they're going to be having repeat, let's say, CAT scans, PET scans, and staging of the cancer along the way, done in a freestanding physician-owned radiology facility versus a hospital-based facility. Likewise, not duplicating care. If a primary has done recent labs, making sure that it's not duplicated 1 week later by an oncologist, sharing of those resources, sharing of what has been done in terms of staging of cancer. Our medical directors have been very integral in this process of really closing the loop between the oncologist, the primary physician, who is our medical home model that we execute at Florida Blue, as well as then assisting the patient and their family with that approach. We also are focused with giving patients the ability, especially patients with metastatic cancer, not in active treatment anymore, to at least have some assistance with palliative care, making sure that their wishes are known, assisting their family in a difficult time, I think is another key component of our place of delivery model, and assisting on the palliative care side of care. A lot of times, just focusing on the disease itself without really getting that holistic approach that I'm describing, from the social determinants to the behavioral to the palliative, will not have the best overall outcome for that particular patient. So today I've described what we try to do with physicians. We're very much into partnering, collaborating with physicians in terms of our ACO models that we are now employing statewide with these large cancer groups, oncology groups, as well as then how do we take care with our own internal multidisciplinary teams, a very difficult disease being cancer, and how our different role models within our PODS model execute on that. So I'll be also taking questions and answers towards the end when the others finish. So thank you very much.
Thank you so much, Dr. Haas. It's been really interesting today to hear about all of these efforts to improve cancer care delivery and payment. We know that prevention efforts are still key to reducing cancer risk and the economic toll on patients, as well as federal, state, and local budgets. And we wanted to include today a discussion of state policy progress in reducing cancer. And we're now joined by David Woodmansee, Associate Director, State and Local Campaigns for the American Cancer Society's Cancer Action Network, along with Betsy James, the Senior Manager on the State and Local Campaigns team, also at the American Cancer Society Cancer Action Network, and I will turn it over to them.
Thank you so much for allowing us a few minutes on your agenda this afternoon. We are going to talk specifically about a document that we've published for the last 15 years called How Do You Measure Up? Betsy and I work on the state and local campaigns team, and we are split into two portfolios. One is the Access to Care team, which I head up, and that has to do everything with anything that any sort of screening or any sort of when cancer patients have cancer and they're undergoing their treatment, any insurance issues, any access issues, network adequacy, quality of life issues, all the issues that cancer patients and their caregivers go through. And then we have a prevention portfolio, which Betsy is part of that team. And, the real goal of that team is to make sure that my team doesn't have a whole lot of people to worry about. But unfortunately, in the cancer world, we do have a lot of people that have cancer and are quote-unquote cancer survivors that are still battling the disease. So what we try to do is in this document, as I mentioned, this is the 15th year we've done this, we try to measure some of our organizational priorities around access and prevention. And this is a legislative snapshot year to year of the policies that are in place in a given state. There's also regulatory work. We do not measure that in this document, but this is a document that measures our legislative work on many priorities. It's a 57-page document. It is policy-centric, but we go out of our way to try to make it user-friendly and tell the patient stories, tell the survivor stories, and point out some creative and clever wins on the state level. To get into a little more detail on that report, I'm joined by Betsy James, and she's going to take it from here. So, Betsy.
Thank you, Dave. Thanks, everyone, for your time today. I'll just begin by saying that you can access this report on our website. It's acscan.org/measure, and you can certainly reach out to me for hard copies should you need those as well. I'm so glad for the intro because we have been talking a lot about access, and I'm glad to talk a little bit about prevention as well because we know that about 1,650 people die in the United States every year from cancer, and roughly half of those could be prevented with if people could quit tobacco use, if they could exercise regularly, if they could eat a healthy diet, and get their recommended screenings. And so what we're going to see here in this report is how those policies can make those changes that we would all love to see. The way the report works is through a red, yellow, green rating system. And so if a policy is either non-existent or poor, we give it a red. If it's, approaching the goal, we give it a yellow. And if it's a benchmark that's an evidence-based policy, it's effective, it's what we would recommend, then it gets a green. So that said, we have a lot of work to do. Only Massachusetts has reached 6 of the 9 benchmarks that we measure, and California reached 7 of the 9 benchmarks, but those are the only states that even come close to reaching all 9 greens. And in fact, the report found that about 20 states reached green in only 1 or 2 areas. So we have a lot of potential, but we also have come a long way since this report started. And just as an example, our SmokeFree Map, when we started this report, we had 2 green states, and now we have 25. So thanks to all the work of our advocates and our partners, we've come a long way, but we're here to show you today that we've got a long way to go. So I'm just going to go back here to the tobacco tax slide. So our cigarette tax is currently at $1.71 per pack on a national average, and that just recently changed. So Delaware, Rhode Island, and California all passed or implemented or did implement taxes in the 2017 year that just went into effect September 1st. So that national average is brand new. And as you can see on the map, we kind of have a mixed bag in this area. We've got several green states. We've got a mix of yellow and red. And you can kind of see some patterns as I go through these maps that we've got some shared goals in certain regions. So next I'll show you the SmokeFree Map. And on this map, unfortunately, we did not get anyone to green in the last year. Smoke-free progress has somewhat stalled. But the good news is that local progress continues. So 70 local communities passed the smoke-free law this year. So our work is certainly not over in this area, and we hope to see some statewide bills pass. And we certainly have states that are organizing and planning to pass those laws in the near future. Our next slide here is just a snapshot of our work when it comes to healthy eating and active living. As I mentioned, that's a big part of cancer prevention, and we think that about 20% of cancer cases can be attributed to unhealthy eating, inactivity, and excess alcohol consumption. So here's a snapshot of the policies in that area. There's too many to put on a map, but what we kind of want to demonstrate in the report is that it's not going to just be one silver bullet policy when it comes to our obesity epidemic. It's going to take many policies working together in the activity space and the nutrition space to really build some synergy and really tackle this, like I said, what I called it and what everyone's calling it, an obesity epidemic. And we're just transitioning here to our tanning slide. This is a law that we've worked on in many states to prohibit minors from using tanning devices, and we use the age 18 as the rule there. And this year, Oklahoma and West Virginia passed tanning laws, and so that makes 15 states. And as you can see, this state or this map does not necessarily flow with other regional maps or what we might think of as like red state, blue state maps. There's really some great activity happening in here in some unexpected places, and so we're really excited to see that some folks might have thought that a tanning law was a non-starter in a place like Texas, but they were actually one of the first, so we're really glad to see progress in that area. So again, kind of like our healthy eating, active living agenda, our access to care portfolio is very broad, and we have almost too many issues to mention in a map, but we do want to, explain to readers and to legislators that we have a lot of new emerging issues and a lot of great solutions that can be put into place to help cancer patients and potential cancer patients. So what we did here is we put some infographics in place that kind of talk about network adequacy, surprise billing, various other issues, and then we also link, we do a list of certain policies that we approve and that will work, and then we link to state bills that we thought the language was good. So this, like I say, kind of takes a different approach, but does give legislators an idea of the kind of work that we want to see when it comes to access to care. And Dave, did you want to add anything on that?
Thanks, Betsy. Just that obviously with cancer care, there are certain doctors that need to be in a network for cancer patients to be able to access, depending on their type of cancer. And there has to be some sort of geographic sense to how far people have to travel to see specialized to see specialized care for their cancer. So those are some of the type of things that that we are paying attention to, and the telemedicine also telehealth is something that's relatively new on the horizon, and that we're looking at how we can help make that a reality for people where that it makes sense for. Obviously, telemedicine is not going to be adequate in certain instances. So we have to have some sort of common sense in our policies around that. We are getting up to speed on that, but that is an emerging issue that for us, anyways, that Betsy was referencing.
Thanks, Dave. So our next map is measures which states have expanded Medicaid and which have not. So we're up to 32 states, and this is really a core policy for us. I mean, it's at the root of what we do, getting our cancer patients access to care. And we've done a lot of research explaining that without access to care, people are less likely to get screened. They're more likely to be diagnosed later when cancer is harder to treat. So there are all sorts of reasons that our constituency needs good access to care. And like I say, this is one of our absolute just core issues that we focus a lot of time and energy on.
Yeah, and besides expansion, I'll just add, we are spending a lot of time in the last year or so, 8 months, trying to protect Medicaid in the states. It is an important safety net program for a lot of working poor, and a lot of people don't know, although some of the people on the phone will probably know because you're professionals in this area, but 1/3 of all pediatric cancer patients are in the Medicaid program, are treated through the Medicaid program. So a lot of people don't realize that, 1/3 of the it's almost 1/3, 31% to be exact. But a lot of children fighting cancer, dealing with cancer, are in the Medicaid program, the traditional Medicaid program. So that's a very important program for us to protect.
Our next slide measures pain policy in the United States, And this is based on the Pain Policy Studies Group survey at the University of Wisconsin. So as you can see, again, we've got a lot of states in yellow. We've got few in green, a couple states even in red. And Dave has worked hard to help states really craft language and find that balance when it comes to dealing with opioid crisis, but then also making sure that cancer patients have access to the care that they need. So, Dave, I'll let you say a word about that, too.
Yeah, that's exactly right, Betsy. I do spend a lot of my time working with our folks on the ground in the state, and we are fortunate. We have people on the ground in every state capital. We have a dedicated staff lobbyist, and then we have a grassroots director. But I spend a lot of time helping our folks try to craft policies that are balanced. There's no denying every state in this country there's a terrible crisis with abuse and diversion of opioids, and we need to address that. But while we're addressing that, we need to remember that millions of cancer patients and cancer survivors are, have legitimate needs and use the way they're supposed to be used, opioids, to get through their day or their night with some decent level of quality of life. And, we've seen the pendulum swing, especially with the CDC's guidelines that were published in January of 2016, where some state lawmakers and regulators rushed to create legislation or regulation proposals that would make the CDC's voluntary guidelines law, and law for all docs, not just for primary care docs, which those voluntary guidelines were intended for. And the CDC voluntary guidelines clearly stated that it was not to pertain to cancer care. But in the states, that has become the norm in several places. So we spend a lot of our time trying to talk to legislators and policymakers about the need to have balanced pain policies where people that legitimately need those meds can access them, but people who, would abuse or divert them are prohibited from getting them. And prescription drug monitoring programs, have been a wonderful tool that is relatively new in the last decade to help with that. And every state in the country now has a PD prescription drug monitoring program in place, except for Missouri. The jury is still out on that one. The governor has proposed an executive order, but there's some problems with that about how effective it will be the way it is currently constructed. But we are working on that, and we will continue to work on that.
Thanks. And with that, we'll go to our last map. Now, I should have mentioned I didn't put all 9 maps in here just because we have limited time and limited focus. But our last map in this presentation is on palliative care, which we've obviously talked a lot about on this webinar. And Dave in large part developed model palliative care legislation just a few short years ago, and it has been introduced and passed in 20 states now. So 20 states have palliative care councils. They have state-supported websites that give information about palliative care resources. And then all of the yellow states have introduced that legislation. So this is about almost half the country or over half the country either has a law or is working on a law to increase access to palliative care. So we're very proud of the quick progress we made in this area. And just even in the last year, we passed it in 7 states. So this is obviously a hot topic. And Dave, go ahead.
Yeah, I was just going to mention that, getting to 20 states in 4 years is we're pretty happy with that. But if you look at the map, and Betsy mentioned this for the tanning map, if you look at the map, these are not the traditional states that are green on our maps when you look at the entirety of our maps. And as a matter of fact, we've passed this legislation in 12 quote-unquote red states as opposed to 8 blue states, which really tells us that this is truly a bipartisan issue and that people understand what the benefits are of palliative care, not only for patients and survivors, but for caregivers and family members. And if done correctly, palliative care can save, can limit costs in some instances and improve outcomes. So it's truly a win-win situation. And it's not rocket science what we've proposed on the state level. There's so much good that's happening around the country and in the states in palliative care and palliative medicine. All we're doing on the state level is passing a way for people to coordinate what's happening, all the good things that are happening in a state, so that the awareness is raised and thus the utilization is raised, which brings us to an interesting issue that as awareness and utilization increases, we're going to need the medical professionals, the specialists in palliative care, and that's what our federal legislation aims to do, is create monies that the states that can be given to the states for continuing education and for furthering education for those that want to make palliative medicine a specialty. So, we're really happy with what's going on the state level, and now we're working hard to get to the other 30 states, and we're also working hard at the federal level to try to make sure that, they're doing their part so that, the professionals that want to be specialized in palliative services can do just that. So we still have some work to do. We're making progress, but we at least have the needle pointed in the right direction, we believe.
Yes, and I'm glad Dave mentioned our synergy with our federal work and our state work, because next week we'll all be together in D.C. with over 700 of our volunteers lobbying Congress on cancer research dollars, which we spend a lot of time at the federal level doing with our volunteer forces. But we also do research advocacy at the state level. So, of course, we want cancer registries funded and cancer control programs funded. And then what we do in the report is highlight a few states that go above and beyond in their research programs, like in California and Florida and Texas. So, again, I encourage you to look at the report. It is online, acscan.org/measure. And as Dave mentioned earlier, also you'll find great stories about our volunteers, about where we were successful, where we came up short in different legislative campaigns. So there's a lot more to the report than just these maps. But thanks again for the opportunity to share, and I'd be happy to take questions at the end as well.
Great. Thank you.
Thank you. Thank you both so much, and thank you to all of our speakers. We're going to start our Q&A session. Quite a few folks have submitted questions already. You can continue to submit them, and we'll do questions for the next 10 minutes or so. If our speakers want to come off of mute and try to direct questions to you, kind of going back here, we have a question that I think is for Lara. How did you customize your model to cater to the provider readiness in the markets that you entered into and that were part of the OCM? And how did you and how did they identify which providers were the most ready to begin participation in the program?
Thanks, Catherine. It's a great question. So we, as I mentioned a few minutes ago, we have a wide range of practices participating in the model, not only in aspects like geographic location and size, but also their readiness for transformation. All of the participants that we have in the model, it's a voluntary model, so practices had to submit an application to participate, and there was an application review process and certain criteria that needed to be met. So all of our practices that have signed on to participate with us exhibited a degree of readiness to the extent that they were willing to submit an application that was thoughtful and addressed the various requirements, including their ideas around how they would implement the different activities required by OCM. But that being said, we didn't require that they have a certain stage of readiness beyond a commitment to implement all of the activities within 3 months of the model starting. So we have currently a wide range of practices in terms of their sophistication in each of the different activities and the extent to which they were doing some of them before OCM started, and to the extent that they're brand new to those activities. So the first few months of the model were really focused on ramp up for everyone to get to a place where they could do each of the redesign activities. And then as we go forward in the model, as I mentioned earlier, we're really focused on trying to support practices and evolving their approaches over time to become more sophisticated and really reflective of best practices. In terms of which providers at the organization are, the target of OCM, I will echo something that I said earlier, which is that we're really focused on whole practice transformation. And for the financial piece of our model, where we hold practices accountable to targets, all providers at the organization that are providing cancer care for patients receiving chemotherapy can trigger episodes of care and are then going to be part of that calculation of a potential performance-based payment or not. So we ask that all providers that qualify according to our criteria are part of the model and are engaged in the redesign activities that we have. So it's really focused on bringing whole practices along, not just portions of practices.
Great, thank you. An additional question, Lara, for you about plans participating. The question is whether there are any Medicare Advantage prescription drug plans cooperating with OCM, and if not, why not? They'd seem relevant partners, or if so, which ones?
Yeah, thanks. That's another great question. So on our website, you can find the commercial plans that, or payers rather, that we are participating in the oncology care model with, and each of those payers has the ability to participate in OCM with whichever lines of business that they wish. So I can't answer off the top of my head the extent to which we have Part D plans that may be part of the broader organizations and payers that we have participating, which ones they may choose to include. I will note that payers do have latitude around how they define chemotherapy in their model and which aspects they want to target. So in the Medicare fee-for-service side, we are really focused on chemotherapy as a broad concept around drugs that are anti-cancer. So we do include hormonal therapies in that definition. And some payers have chosen not to include hormonals. Some have chosen not to include orals altogether, so also including non-hormonals. And so that may change the extent to which they might be interested in having their Part D plans be part of their efforts.
Great, thank you. This question for Dr. Haas, the Florida Blue, could you explain, or the case managers, the nurses, the pharmacists, everyone that's participating in that place of delivery model, could you explain, are they employed by Florida Blue, part of the oncology practices, a third party, kind of how's the reimbursement working for that?
The care model, the place of delivery model, PODs, they are employees of Florida Blue, so they are involved with cases that we get triggered into our model. So when a new diagnosis is made of cancer, they are triggered in, our case manager then engages and then will involve the other team members. For example, if the case manager is speaking to a particular patient and they find that transportation is an issue or meals is an issue, they'll get Meals on Wheels, they'll coordinate with transportation services. If there's affordability, they'll look for, let's say, the Medicare Advantage and low-income subsidy they may qualify for. If they see that there's a pharmacy issue, they will also involve our clinical pharmacists, but they are all employees of Florida Blue.
Okay, great. A follow-up question, you would also mention, how that model can help with medication adherence, and we know there's been some studies this year about cancer patients not filling prescriptions or not, taking prescriptions due to cost. And could you elaborate a little bit about kind of how that team and how these different payment models can help with medication adherence?
Well, we try to, involve our clinical pharmacists as soon as that may come up, and to see, is the patient on a particular pathway? Are they, have other drugs been tried along that pathway, or has a particular oncologist, let's say, jumped all the way to a bottom of the pathway, and there are other alternatives in between? Then our clinical oncologist, our medical director, would have a peer-to-peer with the oncologist and let them know that this fifth-tier drug, you haven't really gone through the normal pathway cycle like your peers, and this is definitely having an impact. This patient is having affordability issues. We're wondering why you jumped to the bottom of the pathway here rather than the normal course, which is customary and standard, one would think. We had one particular patient that our community social worker and pharmacists work together in, and of affordability. Sometimes we'll go to not only looking for low-income subsidies. If someone happens to be a veteran, we'll ensure that they're getting resourcing even through the VA in terms of help with oncologic drugs. This particular veteran joined the Medicare Advantage plan, had affordability problems. We looked for other resources. We marshaled even the Wounded Warriors Association. They helped out in terms of some of the cost share with him until the VA was coordinated with our community social worker, and this veteran was able then to get full coverage, and nothing was falling through the gap in terms of making sure he was able to afford his copays, get the different medications he needed. So it is something very difficult. If somebody is on chemo infusion drugs, we try to coordinate with the oncologist to make sure if it can be done in the office versus in the hospital, to try to avoid having a patient pay $500 or $1,500 every time they're admitted once monthly into the hospital for chemo, or a significant copay to have it done in the outpatient hospital versus the physician's office.
Thank you. Lara, another question for you. Can you talk a little bit more about survivorship planning under OCM, and how is it being incorporated, and what type of elements are we seeing in the survivorship plans?
Sure, yeah, happy to. At a high level, I'll say that so one of the redesign activities we require practices to implement is the IOM care plan. So the Institute of Medicine recommended that all cancer patients have a care plan that includes 13 different elements, and one of those elements is a survivorship plan or survivorship planning. So we have heard from practices that for some of their beneficiaries, obviously, depending on the point in care, the survivorship planning isn't yet relevant. So to the extent that patients get to a point in their care where survivorship planning becomes a topic that's appropriate, then practices are required to do that as part of the care planning for participating in OCM. How practices are actually doing their survivorship planning, I think, looks different depending on the practice, and that's one area where we actually have an upcoming event through our learning community where we're planning to have a few different practices present to our larger group of participants around what they're doing and what it looks like for them. We purposely don't dictate specifics about how each of those elements of the care plan must be done. We try to remain flexible given not only the heterogeneity of practices that we have participating, but also the wide range of patients that each practice has and the different needs that each patient might bring to the table. So we are certainly hoping to learn quite a lot from our practices about what they're doing and how well it's working.
Great, thank you. We are out of time today for our Q&A and our webinar, but I'd really like to thank our panel of speakers for joining us today and invite our audience to take a moment to share feedback from this event. There's a brief survey which you can access by clicking on the button on the bottom of your screen, and you can also find information about our next webinar if you click on the link on your screen as well. So thank you all again for joining us today.